Hi, I'm going to talk about the combinate angiotensin inhibition for the treatment of the diabetic nephropathy. The diabetic nephropathy, this is a nephropathia diabetica, also known as Wilson syndrome, or nodular diabetic glomerulosclerosis and intercapillary glomerulonephritis. It's a progressive kidney disease caused by angiotherapy of capillaries in the kidney's glomeruli. It is characterized by nephrotic syndrome and diffuse glomerulosclerosis. It is due to a long-standing diabetes mellitus and is a prime indication for dialysis in many developed countries. It is classified as a microvascular complication of diabetes.
The development of diabetic nephropathy involves hypertension and hyperglycemia-induced changes in multiple pathways that contribute to morphological changes in the kidneys. The glomerulus is a globular-shaped structure composed of capillaries that are actively involved in the filtration of fluid from the blood to form urine. With diabetic nephropathy, early glomerular hemodynamic changes include hyperfiltration and hyperperfusion, which result in microalbuminuria. Increased afferent arteriole dilation due to a dysfunction in the vasoconstrictive autoregulatory response contributes to increased intraglomerular pressure, which is associated with greater mesangial cell matrix production. Expansion of the mesangial area, an early morphological change with diabetic nephropathy, is caused by greater extracellular matrix deposition and mesangial cell hypertrophy. This expansion is associated with a decreased glomerular filtration rate and a reduction in the surface area for filtration, which marks the beginning of renal failure. As this process continues, the glomerular basement membrane thickens, and this may eventually lead to glomerulosclerosis. All of these changes in glomerular hemodynamics cause stress and strain on the kidneys, which, if left untreated, may result in renal failure.
Okay, the clinical syndrome characterized by the following: the persistent albuminuria, measure the 300 milligrams to 300 milligrams, or measure to 200 milligrams per minute. That is confirmed on at least for 2 occasions, 3 to 6 months apart. The progressive decline in the glomerular filtration rate, the elevated arterial blood pressure. The angiotensin is a peptide hormone that causes vasoconstriction and a subsequent increase of blood pressure. It is part of the renin-angiotensin-aldosterone system, which is major target for drugs that lower blood pressure.
Renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system is a classic endocrine system that helps to regulate long-term blood pressure and extracellular volume in the body. The system begins with the release of angiotensinogen into circulation by the liver. This may be in response to low blood pressure and adverse changes in sodium concentrations. An enzyme, renin, is secreted, which cleaves angiotensinogen to form the inactive decapeptide angiotensin 1. Further transformation of angiotensin is carried out by angiotensin converting enzyme, or ACE. This is predominantly found in the pulmonary circulation. However, ACE is also produced in the vascular endothelium of many tissues, including the kidney, adrenal gland, brain, and heart. The angiotensin converting enzyme converts the inactive precursor angiotensin 1 into the vasoactive peptide angiotensin 2. In addition, alternative pathways exist that do not rely on either renin or ACE. In non-renin pathways, enzymes like tonin and cathepsin D release angiotensin 1 from angiotensinogen and tissue plasminogen activator, or TPA, and can make angiotensin 2 directly from angiotensinogen. This bypasses the midway production of angiotensin 1. Enzymes like kinase can form angiotensin 2 from angiotensin 1 via an ACE-independent pathway. Angiotensin converting enzyme also degrades bradykinin, which is required for synthesis of a major vasodilator, nitric oxide. Angiotensin 2 binds AT1 receptors expressed on the surface of vascular endothelium and impairs nitric oxide synthesis as well. Reduced bioavailability of nitric oxide combined with the stimulation of AT1 receptors on smooth muscle cells causes vasoconstriction. In addition to a vasoconstriction effect, stimulation of AT1 receptor causes the adrenal glands to release the hormone aldosterone, resulting in sodium retention. Combined with vasoconstriction, this increases blood pressure. In the final stages of RAS, the kidney reduces the production of renin. Most of the known actions of angiotensin 2 are mediated through the AT1 receptors, which can be found in the kidney, heart, vascular smooth muscle cells, brain, adrenal glands, platelets, adipocytes, and the placenta. Angiotensin 2 type 2 receptors can be found in low levels mainly in the uterus, adrenal, central nervous system, heart, and kidney. AT2 receptors appear to counteract the effects of AT1 receptor stimulation. Another angiotensin 2 type receptor is the AT4 receptor. Its stimulation may increase synthesis of the natural inhibitor of TPA called PI1, thereby reducing effective fibrinolysis. Stimulation of AT4 receptor appears also to promote cell growth and proliferation.
Okay, in this study, this study was stopped early owing to safety concerns. Among 1,448 randomly assigned patients with a medical follow-up of 2.2 years, there were 152 primary endpoint events in the monotherapy group and 1,132 in the combination therapy group.
Why are we calling blood pressure medicines first-line therapy or second-line therapy? Well, first-line medications, as I mentioned before, are usually ACE inhibitors or angiotensin receptor blockers, ARBs. And these are used almost always because of the fact that we want people to have kidney protection as well as heart protection. And we know these drugs do that. So why is it then that we have to have all these other different blood pressure pills around? Well, unfortunately, one blood pressure medicine usually is not enough to control blood pressure in people with diabetes. What is the average number of blood pressure pills that people with diabetes are on? 2 or 3. So it normally happens that it takes 2 to 3 blood pressure medicines to control your blood pressure. Now, if you're on one and it's controlling it great, congratulations to you. But most people with type 2 diabetes actually need 2 or 3 blood pressure medicines to actually control their blood pressure. It's important to understand that the problems that I see a lot have to do with the misdosing of these types of medications. So it's important to understand that many people like to put you on a very low dose So what will happen is you'll come in, you'll have high blood pressure, and the doctor will start a very low dose of a medicine. Well, the most effective dose of most of these medicines is about half maximum dose. So it's very easy now on the internet to look up the maximum dose of these blood pressure pills and figure out, in conjunction with that, what dose are you on? The maximal effective dose is usually about the half maximum dose. So take a look at your blood pressure pills and see what you're on. If you're on a very low dose of one blood pressure pill and your blood pressure is still uncontrolled, it may be worthwhile to either increase that blood pressure medicine or add a second or third line medication. Anything other than an ACE or an ARB is really called a secondary medication or a tertiary medication or third line blood pressure medicines for the treatment of high blood pressure. But what's most important is most clinicians will add as many blood pressure medicines as you need to get your blood pressure to the goal that we mentioned before, which is less than 130 over 80.
Okay, in the conclusions of this study, well, the combination therapy with an ACE inhibition and ARB was associated with an increased risk of adverse events among patients with diabetic nephropathy.